Usually when you picture a modern operating room, if you're like most people, you probably imagine this scene of almost like engineered precision.
Oh, absolutely.
Right. Like you think of the bright sterile lights, the rhythmic beeping of the anesthesia monitors, and this very binary, clear-cut outcome.
Yeah, you go to sleep, they fix the problem, you wake up.
Exactly. The patient goes to sleep, the surgeon goes in, removes the bad things, stitches everything back up, and, the patient is cured. It feels very mechanical, doesn't it? Very black and white.
Right. There is this comforting, almost cinematic illusion that surgery is just about knowing where to cut. We really like to think of the human body as a machine and the surgeon as simply a very highly trained mechanic.
Like taking your car to the shop.
Exactly like that. You bring your car to the shop, they replace the alternator, and you drive away. Broken or not broken, fixed or not fixed.
But then you step into the world of major abdominal and pelvic operations, which is specifically the kind we were exploring today. And suddenly that simple mechanic analogy just, well, it falls apart completely.
It really does. It shatters.
Because you aren't working on a static machine that's turned off in a garage. We are looking at an environment that is much more like, I don't know, a high-stakes, real-time chess match.
Well, that's a great way to put it.
Where the board is actively changing shape while you play, and every single move, every incision, is a calculated decision that fundamentally alters the rest of the game.
Yeah, it is the absolute definition of a dynamic, unforgiving landscape. You aren't just dealing with structural anatomy. You are dealing with this cascade of physiological variables that can shift in, literally a matter of seconds.
Right.
Blood pressure drops, tissues swell, unexpected variations in blood vessels just appear out of nowhere. The terrain fights back.
And that actually brings us to the mission of today's deep dive. We are exploring a source today that I found just utterly fascinating. It's a text called Colorectal Surgery Code, a practical illustrated guide to open, laparoscopic, and robotic colorectal surgery by Dr.Atef Ahmed.
Such a comprehensive text.
It really is.
Yeah.
Now, I know what you might be thinking if you're listening to this on your commute or, while walking the dog. I'm not a surgeon. I'm not in medical school. Why am I listening to a deep dive on a clinical surgical textbook?
Right. It sounds a bit niche at first glance.
It does. But trust me on this. This text is not just for medical professionals. What Dr. Ahmed has actually written here is this masterclass in high-pressure decision-making, spatial awareness, and structured problem-solving that anyone in any profession can deeply appreciate and learn from.
I completely agree with that. The book is, ostensibly about the mechanics of the colon and rectum, the technical steps of removing cancer or treating severe inflammatory disease. But at its core, it is a treatise on how a human being processes incredibly complex life or death information under extreme stress, and how establishing a mental framework, a code, is what separates a successful outcome from a catastrophic failure.
Okay, let's unpack this. Our goal today is to decode this surgical framework that Dr. Ahmed presents. We are going to journey from the abstract philosophy of how a surgeon thinks before they ever touch a scalpel down into the, frankly, terrifying, unforgiving anatomy of the human pelvis.
It is a rough neighborhood down there.
Seriously. And then finally into the mechanical precision of modern surgical robots. And a quick heads up for you listening, later in the deep dive, we'll actually talk about how this kind of specialized knowledge is accessed by the people who need it most. And I'll be sharing a massive, exclusive 80% off promo code for this comprehensive medical library.
That is an insane discount.
I know, 80% is huge, but we'll get to that. To really grasp its value, we have to start where Dr. Ahmed starts in the text.
Right. We begin not with the physical tools, but with the mind.
Because before we can understand the mechanics of how a surgeon cuts, we have to understand the logic of how a surgeon thinks.
Exactly. Dr. Ahmed's central premise early in the book is that surgery is not just a physical act of dissection. He describes it as a continuous sequence of answers to the question, why?
Like constantly questioning yourself.
Yeah, exactly that. It's a crucial distinction. Why this specific operation for this specific patient? Why enter this exact anatomical plane and not the one, 2 millimeters to the left?
Oh, wow.
Right. Why divide this specific blood vessel right now? Why create this this reconnection of the bowel in this particular way?
So it's not just following a recipe.
Not at all. If a surgeon is just going through the physical motions of a memorized procedure, essentially just like Painting by number without constantly answering those whys based on the tissue right in front of them,
Right.
they're actually operating unsafely.
To structure these whys, the text introduces this visual concept called the Master Colorectal Surgery Code Wheel. And it has 4 main pillars that support the entire operation: preoperative optimization, surgical anatomy and dissection, oncologic clearance, and anastomotic integrity. Now, when I first looked at this code wheel in the book, my immediate thought was to compare it to a pilot's pre-flight checklist.
Okay, I like that.
Making sure the flaps are working, checking the fuel levels, going down this rigid step-by-step list before you're cleared for takeoff.
That is actually a very apt analogy for that first pillar, preoperative optimization.
Yes.
Historically, surgery was approached with a somewhat passive mindset regarding the patient's physical state.
Like just don't eat after midnight.
Pretty much, you just told him to fast after midnight and hope for the best. But Dr. Ahmed emphasizes a modern paradigm called ERAS, which stands for Enhanced Recovery After Surgery.
Okay.
This is the concept that the best operation actually begins weeks before the first incision. The surgeon has to act almost like a sports coach, assessing the patient's cardiopulmonary reserve, evaluating their frailty, and specifically intervening to optimize their nutrition.
I want to dig into that nutritional aspect because the text points out something very specific. It talks about checking the patient's albumin levels.
Ah, yes, albumin.
It states that making sure albumin isn't below 3.0 grams per deciliter is this crucial step. Now, for those of us who aren't reading blood panels every day, what exactly is albumin and, why does the surgeon care about it so much?
Well, albumin is the most abundant protein in human blood plasma, and it's produced by the liver. It's essentially a proxy marker for a patient's overall nutritional status and systemic inflammation.
Okay, so it's a marker.
Right. Think of it as the raw building material the body uses for repair. If you are going to inflict a massive, controlled trauma on a patient...
Which is what surgery is.
Exactly. Surgery is controlled trauma. And if you expect their tissues to heal and fuse back together after that trauma, they need building blocks. If their albumin is below 3.0, they are malnourished. Their body simply doesn't have the physiological capital to heal the wound.
Wow. So if you operate on someone with low albumin, what happens? Do stitches just, not hold?
Essentially, yeah. The tissue lacks the protein necessary to synthesize collagen and create a strong scar. So, correcting that anemia and malnutrition before the patient even enters the OR, maybe through, specialized nutritional drinks or intravenous iron, is what sets the stage for a body that can actually survive the procedure.
That makes total sense.
Yeah.
But here is where I want to push back on my own pilot's checklist analogy.
Okay, let's hear it.
A pre-flight checklist is incredibly rigid. You do step A, then step B, then step C in that exact order every single time. But when you are inside a human abdomen, is it really that rigid? Humans aren't Boeing 737s coming off an assembly line. What happens when things inevitably look different or go wrong in the middle of a procedure?
What's fascinating here is that the code wheel is explicitly not a rigid step-by-step script. It is a dynamic framework.
Dynamic. Okay.
And the reason a dynamic framework is vastly superior to a rigid script in this environment is that it prevents cognitive overload. When a surgeon is facing an unexpected complication, say a massive tumor that has completely distorted the normal anatomy, or a sudden, unexplained drop in blood pressure, they don't panic and try to remember step 42 of a textbook. They retreat to the fundamental pillars of the code wheel.
So they fall back on first principles. They stop trying to force the script and look at the underlying rules of the game.
Precisely. Let's look at the fourth pillar of the wheel as a prime example of this, anastomotic integrity.
Yeah.
An anastomosis, simply put, is the surgical connection made between two pieces of bowel after a diseased section has been removed.
So you cut out the cancer, and you have to sew the two healthy ends back together so the digestive tract functions.
Exactly. Dr. Ahmed outlines the absolute non-negotiables, the first principles for this pillar.
What are those non-negotiables? Because, just from a plumbing perspective, sewing two soft, wet tubes together seems incredibly precarious.
It is, which is exactly why the principles are so strict. First, you must ensure a tension-free reach. This means the two ends of the bowel aren't pulling against each other.
Oh, because if they pull...
If there is tension, the stitches will slowly tear through the tissue like cheese wire over the next few days.
Oh, God.
Yikes.
Yeah, not a good visual. Second, you must ensure adequate blood perfusion.
Right, because if you stretch the bowel too far to make it reach, you might kink or stretch the blood vessels supplying it.
Exactly right. And tissue without a robust blood supply will become ischemic, meaning it will die. and dead tissue cannot heal. The connection will just rot and fail.
Unbelievable stakes.
And third, you must perform intraoperative leak testing. The surgeon will often clamp the bowel, submerge the newly sewn connection in a pool of sterile fluid inside the pelvis, and then use a scope to pump air into the rectum.
Wait, it's literally like checking a bicycle tire inner tube for a puncture in a bucket of water. You're looking for bubbles.
It is exactly like that. If you see air bubbles rising through the fluid, you know the seal is imperfect, and you have to add more stitches right then and there.
Wow. But here is where the dynamic nature of the framework comes in. What if the surgeon evaluates the situation, does the leak test, looks at the tissue, and realizes the risk of a leak in the days following the surgery is simply too high?
What would make the risk too high if the bubbles aren't there in the operating room? Like if the test is fine, why worry?
Let's say the patient is elderly and frail, or maybe they had a heavy course of radiation to the pelvis to shrink the tumor before surgery, which severely degrades the local tissue quality, making it like woody and less likely to heal.
Okay, that makes sense.
Or perhaps it's an ultra-low pelvic connection right near the sphincter, which is notoriously difficult to heal. The dynamic framework dictates that the surgeon must pivot. They don't just cross their fingers and hope for the best. They alter their overarching strategy.
So what's the pivot? Do they just not reconnect them?
They do reconnect them, but they protect the connection. They create what is called a diverting loop ileostomy.
What is that?
This means they go higher up in the digestive tract, take a loop of the small intestine, and bring it out through a small opening in the abdominal wall, attaching a stoma bag.
Ah, so they divert the entire fecal stream away from the newly healing high-risk connection down below in the pelvis. It's like rerouting traffic around a fragile bridge under construction.
That's a perfect way to visualize it. It gives that precarious connection weeks or months to heal without the stress and bacteria of the normal digestive flow passing over it.
That's so smart.
And then later, in a minor secondary surgery, they close the stoma and restore normal continuity. The code wheel gave the surgeon the permission, and really the mandate, to change the plan. It forces you to constantly weigh the physical reality of the tissue in front of you against the ultimate goal of patient safety.
That concept is so broadly applicable to anyone managing a complex project or a team. You can have a beautiful roadmap, but if you realize the foundation is crumbling in real time, you need a mental framework that tells you it is time to pivot, rather than just blindly marching the original plan off a cliff.
Absolutely. And that transition from the abstract philosophy of the code wheel to active intraoperative decision-making leads us directly to how a surgeon prioritizes these competing needs when the clock is ticking and the patient is open on the table.
Which brings us to the visual model Dr. Ahmed calls the colorectal decision pyramid. And I have to say, when I saw this diagram in the book, my inner psychology nerd just lit up.
Oh, yeah.
Yeah, I immediately thought, this is Maslow's hierarchy of needs, but for surgery.
It's an incredibly powerful analogy because the fundamental logic is identical.
Right. Because in psychology, Abraham Maslow proposed that human needs are arranged in a pyramid. You cannot worry about the apex of the pyramid, things like self-actualization, writing poetry, or achieving your full potential, if you don't have the absolute base layers met, which are food, water, oxygen, and shelter.
Exactly.
The base needs have to be secured first. Dr. Ahmed's pyramid structures surgical priorities in the exact same way. You build from the bottom up.
Let's build that surgical pyramid layer by layer, starting at the foundation. The absolute base of the colorectal decision pyramid is physiology.
Okay.
This encompasses the patient's hemodynamic stability, their physiological reserve, and their baseline nutrition. Just like Maslow's need for oxygen and water, if the patient is hemodynamically unstable, meaning their blood pressure is crashing and their organs aren't getting oxygen, literally nothing else matters.
Nothing else.
You cannot perform a complex, elegant 4-hour cancer reconstruction on a patient who is actively dying from hemorrhagic shock on the table.
So stability is the shelter and the food. If you have that, you can move up to Tier 2.
Yes. Tier 2 is anatomy. This is defining the strict physical constraints of the disease. Where exactly is the tumor located? How deeply has it invaded the wall of the colon? Are there enlarged lymph nodes nearby?
So this is where the detective work happens.
Exactly. This tier relies heavily on the work done before the surgery, using high-resolution imaging like MRI or ERAS, which stands for endorectal ultrasound. The anatomy dictates the safe physical boundaries of the dissection.
So first we ensure the patient can survive the trauma. Then we map the exact borders of the enemy territory. Once you understand those boundaries, you move up to Tier 3. Oncology. And the book is incredibly emphatic here. The text states that radicality is non-negotiable.
This is a critical tier to understand because it defines the entire purpose of cancer surgery. The goal of a curative cancer operation isn't just to scoop out the visible lump you can see with your eyes.
Right, it's not like digging out a weed.
No, it is to meticulously remove the entire embryologic envelope of tissue surrounding that organ, which contains the invisible lymphatic drainage pathways and the blood vessels where microscopic cancer cells hide and travel.
The book uses some heavy terminology here. It talks about executing a CME for colon cancer and a TME for rectal cancer. What do those acronyms actually mean in practice?
CME stands for complete mesocolic excision, and TME stands for total mesorectal excision. Think of the colon and the rectum not just as tubes, but as tubes suspended in a web of fatty tissue, the mesentery that carries their blood and lymph. A CME, or a TME, involves surgically dissecting out that entire intact package, almost like taking a letter out of an envelope without tearing the envelope itself.
Wow, that sounds incredibly delicate.
It is. It requires strict, unyielding adherence to the delicate fascial planes that separate these packages. The golden rule for this tier, which Dr. Ahmed states plainly, is never compromise margin.
Never compromise margin, meaning like never cut too close to the tumor just to make the surgery easier or to save a little extra normal tissue. You have to take the whole package.
Exactly.
Okay, so we have physiological stability at the base. Right. We have the anatomical map. We have the oncologic mandate to get all the cancer and its pathways. Only when those 3 layers are locked in do we reach tier 4, modality.
Right. Only after the first 3 foundational tiers are satisfied does the surgeon choose their weapon, so to speak. Will this be an open surgery with a large incision, a laparoscopic approach using small ports and cameras, or a robotic procedure? The philosophy here is that the modality must serve the oncology and the physiology, maximizing precision while minimizing trauma.
So you don't just use the robot because it's cool.
Exactly. You don't choose to use the surgical robot just because it's a shiny, multi-million-dollar piece of new technology. You choose it if, and only if, it is the best tool to overcome the specific anatomical and oncologic challenges of that specific patient.
That makes sense. The tool serves the goal doesn't serve the tool. And finally, if all of those conditions are met, we reach the apex of the pyramid. The very top point, reconstruction.
This is the self-actualization phase of your Maslow analogy. This is where the surgeon weighs the technical feasibility of reconnecting the bowel against the functional outcome for the patient. It's the elegant, restorative part of the procedure where the anatomy is put back together.
But I want to explore what happens when this pyramid gets stress tested. Let's dig into a phrase you used earlier when we were talking about the physiology base, damage control. How does this pyramid dictate a surgeon's actions in real life when a case is going completely off the rails?
To understand that, let's contrast 2 hypothetical patient scenarios based on the frameworks in the text. Let's call scenario A our optimized elective patient. Let's call him John.
Okay, John.
John has a diagnosed early-stage colon cancer. He went through the ERAS protocol over the last month. His nutrition is great, his albumin is 4.0, his MRI shows a very clear contained tumor. When John goes to sleep, the surgeon can thoughtfully and deliberately climb the pyramid.
Step by step.
Right. They ensure he's stable, they map the anatomy, they execute a flawless CME to get the oncologic margins, they utilize a robotic modality for precision, and they achieve a beautiful functional reconstruction at the apex. John wakes up, his bowel is reconnected, and he goes home a few days later.
The absolute ideal scenario, the pyramid holds firm.
Exactly. Now, let's look at scenario B, an emergency presentation. Let's call her Sarah. Sarah doesn't have a planned surgery. She is rushed into the ER in the middle of the night. She has a perforated diverticulum. A hole has blown out in her colon. She has what's called fecal peritonitis. Stool is freely spilling into her abdominal cavity.
Oh, wow, that sounds awful.
It is dire. She is in septic shock. Her heart rate is 140. Her blood pressure is tanking. Her kidneys are shutting down. She is profoundly, dangerously unstable.
The base of the pyramid, the physiology, is completely crumbling.
It is entirely compromised. And this is where the mental framework of the pyramid saves Sarah's life because it immediately dictates and restricts the surgeon's behavior. The pyramid forces the surgeon to abandon any thoughts of reaching the apex.
So no reconstruction.
You absolutely do not attempt complex reconstruction or an anastomosis in a patient who is hemodynamically unstable, whose tissues are swollen with profound infection, and who is on massive doses of blood pressure medications.
Because if you try to sew that infected, poorly perfused tissue together, it'll just fall apart anyway?
Sure. It will universally fail, and the prolonged time under anesthesia required to do that delicate sewing will likely kill her on the table.
Wow.
Instead, the pyramid dictates a strict damage control mindset. The surgeon performs a rapid, blunt, life-saving resection of the diseased, perforated segment of bowel. They aggressively wash out the infection from the abdomen, and then, rather than reconnecting anything, they create an end stoma.
A bag.
Yes. They bring the healthy end of the colon out to the skin to drain into a bag. This is known as a Hartmann procedure. The sole priority is rapid source control of the infection and getting the patient off the operating table and into the ICU alive.
That is incredibly stark. It's the difference between treating surgery as an elective art project versus treating it as a dynamic, chaotic rescue mission. The framework removes the surgeon's ego, the desire to do a complete, complex reconstruction, and replaces it with the cold, hard logic of survival.
Precisely. The code dictates the action. But even in a controlled elective setting like John's case, executing tiers 2 and 3 of that pyramid, respecting the anatomy and achieving the oncologic clearance, requires the surgeon to have a flawless mental map of the territory they are navigating, which transitions us into one of the most intense and detailed parts of Dr. Ahmed's text.
Exactly. Mapping the battlefield. The book delves deeply into anatomical respect and what it calls the danger zones. And here's where it gets really interesting for me, because this text makes it abundantly clear that the geography of the human pelvis is intricate, unforgiving, and highly, highly dangerous.
The guiding mantra that Dr. Ahmed repeats in this section is profound, and it might seem a bit abstract at first. He says, embryology dictates surgery.
Yeah, when I read that, it took me a second to process. The idea that adult surgical dissection planes are strictly defined by fetal development. How does that actually work in practice?
It is essentially the secret code to understanding the anatomy. When a human is just a microscopic embryo, the primitive gut tube forms and actually herniates outside of the embryo's body into the umbilical cord as it grows and lengthens.
Wait, outside the body?
Yes. It then rotates and returns into the abdominal cavity, bringing its blood supply and lymphatic drainage with it and fusing to the back wall of the abdomen.
So the way it packed itself into the suitcase as a fetus determines where the seams are as an adult.
That is a brilliant way to put it, yes. The text differentiates between the midgut and the hindgut. The midgut, which develops into the right side of your colon, is supplied by a major blood vessel called the superior mesenteric artery, or SMA.
Okay.
The hindgut, which becomes the left side of your colon, is supplied by a completely different vessel, the inferior mesenteric artery, or IMA. Because they originate from different embryologic structures, they have completely different vascular trees and different lymphatic drainage basins.
So they're completely separate systems.
Exactly. So if a surgeon is executing a cancer resection on the right colon, they must follow these original embryologic dividing lines, tracing the SMA to ensure they remove the entire affected lymphatic package without crossing over and damaging the blood supply to the left colon, which needs to survive.
That is wild. You are tracing the ghost of the fetus to cure the adult. And when we get further down into the pelvis, specifically for rectal surgery, the text spends a lot of time talking about something it calls the holy plane, which sounds incredibly dramatic for a medical textbook. What exactly is the holy plane?
It's a term coined by Professor Bill Heald, a pioneer in rectal surgery, and Dr. Ahmed emphasizes it heavily. The holy plane is the precise avascular microscopic space between the mesorectal fascia, which is the envelope of fatty tissue surrounding the rectum, containing the tumor and the lymph nodes, and the parietal pelvic fascia, which is the tough lining covering the bony pelvic walls. Total mesorectal excision, or TME, requires the surgeon to find this holy plane and use very sharp, precise dissection to divide the wispy web-like areolar tissue connecting those two layers.
Avascular, meaning there are no major blood vessels in that exact space.
Exactly. If you stay exactly in this microscopic plane, there is almost no bleeding. The entire cancer envelope is removed intact, preventing a recurrence. And crucially, the delicate spiderweb-like autonomic nerves that rest just outside this envelope, plastered to the pelvic sidewall, are preserved.
But wandering outside of that holy plane is where things get terrifying.
Okay.
The book outlines 3 major pelvic danger zones. We have the presacral venous plexus, the lateral pelvic sidewall, and the anterior dissection plane. I really want to focus on that first one, the presacral venous plexus, because the text makes it sound like an absolute minefield.
It really is.
If it is so incredibly dangerous, my immediate question is, why is the surgeon operating so close to it in the first place? Why not just stay far away?
Because the anatomy forces them to. The presacral venous plexus is a dense, high-pressure network of veins located deep down in the narrow funnel of the pelvis, lying directly against the anterior surface of the sacrum, which is the solid bone at the base of your spine. To achieve that oncologic mandate we talked about in the pyramid, to get the rectal tumor out with clean margins and harvest a minimum of 12 lymph nodes, the surgeon has to dissect the back of the rectum entirely away from the sacrum. They have to operate in the millimeter of space right on top of those veins.
Okay, so it's a tight squeeze. But what happens if you slip? What happens if you step on a mine in this venous minefield?
The mechanical reality of that failure is terrifying. The veins in the presacral space, specifically what are called the basovertebral veins, are unique. They are valveless, and they actually retract directly into the solid bone of the sacrum itself.
Into the bone?
Yes. If a surgeon uses blunt force instead of sharp dissection, or if they lose the holy plane and tear one of these veins, it causes massive, immediate, life-threatening hemorrhage.
But wait, surgeons deal with bleeding all the time. Can't they just clamp the vein or throw a stitch in it or use that cautery tool that burns it closed?
If it were a normal vein in soft tissue, yes, but you cannot clamp solid bone.
Oh, wow. Right.
And cautery doesn't work well on a hole in a bone pouring out blood. The blood just pools incredibly rapidly in this deep, dark, narrow pelvic funnel, instantly obscuring visibility and putting the patient in immediate cardiovascular peril.
So how do you stop it?
It requires extreme, specialized maneuvers that have to be executed blindly through a pool of blood. The textbook describes using sterile titanium thumbtacks.
Wait, literally like a thumbtack you'd use on a corkboard.
Yes, specially designed surgical thumbtacks. The surgeon has to plunge their hand into the pool of blood, feel for the hole in the bone where the bleeding is coming from, and physically press a tack directly into the sacrum to plug the hole.
Oh my God.
Or they have to apply specialized hemostatic agents like bone wax or muscle fragments and hold intense manual pressure for minutes while the anesthesia team fights to keep the patient's blood pressure up. It is a nightmare scenario. And Dr. Ahmed's point is that this nightmare is best avoided by absolute paranoid respect for the embryologic anatomic planes.
Okay, that is the literal definition of high stakes.
Yeah.
The visual of a surgeon having to push a thumbtack into a bleeding spine to save a life is going to stick with me.
It's intense.
But let's say the surgeon successfully avoids the veins, but they make a slightly different anatomical error. Let's talk about the nerves. The book discusses the functional consequences of straying into danger zone 2 or 3 and injuring the superior hypergastric plexus, or the pelvic splachnic nerves.
This is where we have to connect the mechanics of the surgery to the bigger picture of the human being's life after they leave the hospital. A postoperative pathology scan might show that the cancer is 100% gone, which sounds like a total victory.
Right.
But if the surgeon carelessly severs or stretches these microscopic nerves during the dissection, the functional outcome for the patient is devastating.
What do those specific nerves do?
Well, the superior hypogastric plexus controls sympathetic nervous system functions, and the pelvic splanchnic nerves, the parasympathetic nerves, drive critical functions like bladder emptying and the mechanics of sexual function. Iatrogenic injury here, meaning an injury caused by the surgeon themselves, doesn't kill the patient, but it profoundly alters their life. It results in severe postoperative urinary retention and sexual dysfunction. The patient may need to self-catheterize their bladder multiple times a day for the rest of their life, or they may lose sexual function entirely.
That brings us right back to the apex of the decision pyramid, doesn't it? The reconstruction isn't just about restoring plumbing. It's about preserving the dignity, the function, and the humanity of the patient. The level of anatomical respect required here is just staggering.
It really is.
But before a surgeon can even plan to navigate this battlefield, before they map the danger zones for a specific patient, they have to know exactly what kind of enemy they are facing. Which brings us to the clinical evaluation phase of the text, the detective work.
Exactly. We've seen the map of the territory, but now we need to identify the specific threat. Dr. Ahmed provides a fascinating symptom-to-diagnosis clinical map that categorizes patient presentations into 3 main buckets to help the surgeon formulate a plan: bleeding, pain, and altered habits.
Let's start with bleeding, because I think for the average person, any amount of blood in that department immediately triggers sheer panic. People assume any blood means the worst-case scenario, like advanced cancer.
It is an incredibly common fear, and understandably so. But the text is very specific about training the surgeon to differentiate the exact character and context of the bleeding to guide the diagnosis. Not all bleeding is equal.
Okay, how so?
For instance, the book highlights painless hematochezia, which is the passage of fresh, bright red blood without any associated pain whatsoever, as a major red flag for colorectal neoplasia, meaning polyps or tumors. The tumor is fragile and it bleeds silently as stool passes over it.
Okay, silent bleeding is bad. What's the contrast?
Contrast that silent bleeding with bright red blood accompanied by a sharp, tearing anal pain during a bowel movement. That presentation strongly suggests benign conditions like anal fissures or hemorrhoids. The pain is a clue to the location and nature of the problem.
Ah, I see.
Or consider a patient presenting with voluminous dark maroon stool. That is a classic presentation for a massive diverticular hemorrhage higher up in the colon, not necessarily a cancer. The volume, the color, and the presence or absence of pain are vital diagnostic clues.
And altered habits, too. The text mentions things like ribbon-like stools, or a patient who has alternating cycles of severe diarrhea and progressive constipation.
Yeah.
These are presented as classic signs of an obstructive left-sided tumor that is physically narrowing the passage, acting like a partial cork in a bottle.
Exactly.
But here's where I found myself really pushing back and getting a bit confused while reading the text. We live in an era of unbelievable medical technology. We have high-resolution CT scans that can reconstruct the body in 3D. We have MRIs, PET scans, and rectal ultrasound.
I do.
Yet Dr. Ahmed points out that the absolute cornerstone of clinical assessment for a lower rectal tumor is the DRE, the digital rectal exam, just the surgeon's gloved finger. It seems almost archaic in the modern era. If you have a $1 million MRI machine, why is the finger still the cornerstone?
That's a very intuitive question, and it's one a lot of medical students ask. If we connect this back to the physical reality of the operating room, we have to recognize the inherent limitations of technology.
Limitations?
Yeah, imaging tells you what the machine sees. It gives you a beautiful high-resolution picture of shadows, water content, and contrast dye. But a picture is still just a picture. The digital rectal exam tells the surgeon what the living tissue actually feels like.
I'm trying to visualize this. What is the finger feeling that an MRI, which can see inside the tissue, can't detect?
Two critical things: fixation and tone. An MRI can show you a tumor sitting very low in the rectum, but when the surgeon performs a DRE, they are pushing on it, feeling for tissue fixation. Is the tumor mobile? Does it roll freely under the mucosa like a marble under a rug?
Okay.
Or is it rock hard, tethered, and invading deep into the surrounding pelvic floor muscles or the prostate gland? The physical exam tells the surgeon if the tumor is stuck. The second thing it assesses is the patient's true resting and squeeze sphincter tone. The surgeon asks the patient to squeeze, and they physically feel the strength of the muscle.
Ah, so it's assessing the functional dynamic reality of the environment, not just taking a static snapshot.
Precisely. And this immediate physical reality directly dictates the surgical plan, perhaps more than any scan. If the tumor is very low, mere centimeters from the anal verge, and the DRE reveals that the tumor is deeply invasive or that the patient's sphincter tone is already weak or compromised, the surgeon knows right then and there that a sphincter-sparing operation, meaning cutting out the tumor and reconnecting the bowel to the anus, is impossible or highly ill-advised.
Because even if you save the sphincter, it's too weak. They wouldn't have any bowel control anyway.
Exactly. They would be completely incontinent, which is a miserable, socially isolating outcome for a patient. So the DRE dictates that the patient requires a completely different procedure, an APR, an abdominoperineal resection.
And what does that entail?
This is an operation that removes the entire rectum and the entire sphincter complex, resulting in a permanent abdominal stoma.
Yeah.
No MRI can give you that nuanced, tactile evaluation of sphincter tone and tumor fixity the way a skilled, experienced surgeon's exam can. The human touch remains irreplaceable in the diagnosis.
Okay, so the detective work is done, the diagnosis is made, the stage is set, the anatomical danger zones are mapped, and the decision pyramid has been constructed. Now, what physical tool does the surgeon actually pick up to do the job? Let's move into how Dr. Ahmed breaks down the modalities. Open versus laparoscopic versus robotic surgery.
Dr. Ahmed establishes a fantastic guiding philosophy here right at the beginning of this section. He writes, "The approach is a modality, not a mandate."
I really love that framing. It means you don't use a tool just because it's trendy or because the hospital just bought it and wants to advertise it. You use it because it mathematically solves the specific physical problem in front of you.
Exactly. It's about matching the tool to the terrain. The text breaks down the specific mechanical advantages and limitations of each. Let's start with open surgery, which is the traditional laparotomy. This involves a large vertical midline incision down the abdomen, opening the patient up so the surgeon is looking directly at the organs.
Honestly, reading this section, I had to wonder. With robotic surgical platforms that can filter out natural human hand tremors and give the surgeon 3D magnified vision, isn't open surgery destined for the history books? Why would any surgeon choose to slice a patient wide open, causing all that pain and scarring, if they have a multi-million-dollar robot sitting in the corner of the room?
It's a very common misconception that open surgery is obsolete. But Dr. Ahmed pushes back hard on the hype of technology, replacing the need for foundational open surgical skills. Open surgery remains the absolute, undisputed gold standard for acute emergencies.
Like Sarah, the patient with the perforation.
Yes, for hemodynamically unstable patients, like our hypothetical patient Sarah, and for what the text terms a hostile abdomen.
When I read hostile abdomen, my mind immediately went to severe internal scarring. Like, if a patient has had 3 or 4 previous abdominal surgeries, I imagine the tissue inside isn't pristine and slippery anymore. It's probably fused together with scar tissue, almost like melted plastic. Is that what makes it hostile?
That is a perfect description. We call those dense scar tissues adhesions. An abdomen can also be hostile due to massive acute inflammation from complicated diverticulitis or severe distension because a tumor has completely blocked the bowel, causing it to inflate like a balloon.
No.
In these chaotic, distorted scenarios, minimally invasive tools, cameras, and thin instruments inserted through tiny holes can actually be incredibly dangerous. You can't see past the swollen tissue and you don't have room to maneuver.
So what happens if you start a surgery with the cameras and then you discover it's a hostile environment?
Dr. Ahmed explains a critical concept called tactical conversion. Let's say you start a case laparoscopically, but you encounter dense, impenetrable adhesions, or worse, you accidentally nick a major vessel and encounter massive, unexpected bleeding that obscures your camera lens.
Right.
The camera and the long sticks are no longer enough. The robotic platform, for all its glory and precision, has a massive flaw in an emergency. It lacks haptics. It lacks tactile feedback. The surgeon at the console cannot physically feel how tough or fragile a tissue is.
They're just looking at a screen.
Exactly.
Yeah.
Furthermore, if a major vessel starts bleeding catastrophically, the robot takes precious minutes to physically undock its arms from the patient and roll the machine away.
Minutes that the bleeding patient absolutely does not have.
Precisely. Open laparotomy allows the surgeon to perform tactical conversion, to immediately slice the abdomen open, plunge their bare, gloved hands in, physically feel for the source of the hemorrhage, compress the bleeding vessel with their fingers, and establish immediate control. Haptics, direct physical access, and speed save lives in a crisis. The open skill set is the ultimate safety net.
Okay, that makes total sense. Open surgery is the brute force rescue tool. But for elective planned cases where the anatomy is relatively normal, we have laparoscopic and robotic options to minimize the trauma of a massive incision.
Yes, laparoscopic surgery truly revolutionized the field over the last few decades. By using small portholes instead of a massive incision, it drastically reduces surgical site infections, and it dramatically reduces postoperative ileus, which is the painful paralysis of the bowel that often follows large open abdominal incisions.
But it's hard to do, right?
It is technically demanding. It relies on triangulating straight stick instruments through these tiny ports, and the surgeon must master the fulcrum effect.
The fulcrum effect, like a seesaw.
Exactly like a seesaw. Because the instrument pivots at the point where it enters the abdominal wall. When the surgeon moves their hand to the left outside the body, the instrument tip moves to the right inside the body. Up is down is up.
That sounds like rubbing your belly and patting your head while doing math.
It demands a very specific cognitive rewiring and a unique skill set, especially for the complex medial to lateral dissection approaches favored in colon cancer surgery.
But straight sticks, even when you master the backwards movement, have physical limitations, right? Especially when you're trying to operate deep down in the narrow, bony funnel of the pelvis, which is where the robot finally enters the chat.
Exactly. Robotic pelvic precision. For operating deep in the rigid, bony confines of the male pelvis during a total mesorectal excision for rectal cancer, the robotic platform is transformative. It solves the limitations of straight laparoscopic sticks.
Oh, so.
First, it provides perfectly stable 3D high-definition vision that the surgeon controls directly, rather than relying on an assistant holding a camera. It mathematically filters out any natural human tremor, making the instruments perfectly still. But most importantly, it has articulated wrists.
Articulated wrists. Like the instruments themselves can bend.
Yes. The tips of the robotic instruments can bend, pitch, yaw, and rotate 540 degrees, mimicking and actually exceeding the natural range of motion of the human wrist. They can do this in a space deep in the pelvis next to the presacral veins, where an adult human hand physically cannot fit.
It's essentially like shrinking the surgeon down to the size of a mouse and putting them inside the patient's pelvis with tiny, perfect hands.
That's exactly what it achieves. But again, as Dr. Ahmed stresses in the code, these modalities, open, laparoscopic, robotic, are not competing ideologies or elitist camps. A master surgeon must be ambidextrous in their thinking.
They need all the tools.
Right. They must know how to deploy a robot for a delicate, low pelvic dissection, switch to laparoscopy for a swift mobilization of the upper colon, and have the unwavering judgment to aggressively convert to an open procedure when the patient's physiology or anatomy demands it.
The tool must always serve the code.
Yeah.
Okay, we have covered an immense amount of ground today. We've explored the profound depth of Dr. Ahmed's operational philosophy. We've gone from the conceptual pillars of the code wheel to the tactical reality of robotic wrists and presacral minefield.
You really have.
But we need to talk about how you, the listener, can actually get your hands on this material. Whether you are a medical student cramming for board exams, a resident preparing for a stressful case at 3 a.m., a practicing general surgeon looking to refine your technique, or, honestly, just an incredibly curious, lifelong learner who wants to understand how the human body is actually put back together. This brings us to how this information is meant to be used.
And this is a vital point to discuss. The practical accessibility of the text. Dr. Ahmed designed Colorectal Surgery Code not to be a dusty 1,000-page encyclopedic tome that sits impressively on a shelf but is never read. He designed it as a rapid-access operative guide.
Right.
It is explicitly built to be reviewed in the minutes or hours right before scrubbing into a case. It heavily features visual operative maps, step-by-step technical sequences, and detailed preemptive complication prevention strategies.
Which makes sense because, as we discussed with the danger zones, you don't want to be reading a wall of dense text when you need to know exactly where a nerve plexus is. You need a map. And here's where I get to share that massive exclusive reward we promised you at the top of the deep dive.
This is the good part.
It really is. Right now, you can get an incredible 80% off this book. And actually, it applies to all medical books in the author's collection by using the VIP promo code, AR665398. Again, that code is AR665398.
You can apply that code directly at the official store, which is books.Dr.Atef.net.
Now, I will admit, I am usually a huge fan of physical hardcover books. I love the smell of the paper. I love highlighting things, folding the corners down. And you can absolutely get this text as a beautiful paperback or hardcover on Amazon or Lulu, if that is your preference. But looking at how this specific book is used, I have to point out the absolute brilliance of the digital formats offered at that official store. It's available as an ebook, an Android app, and a dedicated Windows Flipbook program.
And for those who prefer other ecosystems, the digital formats are also distributed across major platforms like Patreon, Buy Me a Coffee, and Gumroad.
But think about the harsh reality of medical training. If you're a surgical resident, you've been awake for 20 hours, you're doing case prep in a tiny on-call room at 3 a.m., and you have to operate at 7 a.m., you do not want to be lugging a heavy hardcover textbook around the hospital in your backpack.
No, absolutely not.
Having a Windows Flipbook on your laptop in the resident lounge or having an Android app right on your phone with these highly visual danger zone maps is literally like having a surgical GPS in your pocket.
Modern medical education absolutely must be as adaptable and mobile as the surgeons themselves. The visual structure of Dr. Ahmed's book is highly intentional. He treats the diagrams not as decorative additions to break up the text, but as true operative maps.
Right, they're functional.
Very functional. When you are about to navigate the presacral venous plexus, or you are trying to visualize the exact dividing line of the superior mesenteric artery, pulling out your phone, zooming in on the fascial plane diagram, and visualizing that vascular pedicle right before you walk to the scrub sink is invaluable. The digital formats make that instant, high-yield spatial review possible when it matters most.
So if you want to understand the code, use the promo code AR665398 at books.Dr.Atef.net and build that ultimate portable medical library. It's an insane discount for that level of specialized knowledge.
It truly is a remarkable resource to have at your fingertips, whether you are holding a scalpel or just trying to understand the people who do.
All right, let's bring this incredible journey to a close. Today, we have traveled deep through the surgical mind. We started by dismantling the mechanic analogy, proving with the foundational pillars of a code wheel that preoperative optimization, albumin levels, and dynamic mental frameworks are just as critical to survival as the physical cut.
We climbed the colorectal decision pyramid layer by layer, learning that basic physiological stability will always trump elegant anatomical reconstruction, and that knowing when to execute damage control, like a rapid Hartmann procedure, is the highest, most difficult form of surgical wisdom.
We mapped the terrifying high-stakes battlefield of the pelvis. We discovered the mind-bending reality that fetal embryology dictates the adult surgical planes, and that absolute, unwavering respect for the avascular holy plane is the only way a surgeon can avoid life-threatening venous hemorrhage and devastating permanent nerve damage.
We explored the clinical detective work, confirming that despite all of our advanced multi-million-dollar imaging tech, the immediate tactile reality of a surgeon's finger during a digital rectal exam remains a non-negotiable cornerstone of diagnostic truth.
And finally, we evaluated the modern weaponry of the operating room, understanding that open laparotomies, laparoscopic sticks, and 540-degree robotic wrists are simply modalities tools that must always bow to the surgeon's judgment and the ultimate safety of the patient.
Which leaves us with a final, lingering thought to consider, and it brings us back to the human element. Dr. Ahmed writes in his preface that while technical confidence, the physical ability to cut and sew, is built over years of repetition, true surgical judgment is built case by case, mistake by mistake, over a lifetime.
The human element,
Yeah.
the unquantifiable art of judgment.
Exactly. And as we race toward a future of medicine that is increasingly dominated by AI-driven anatomical overlays, predictive complication modeling algorithms, and eventually perhaps fully autonomous robotic surgical tools, we have to ask a profound question.
What's that?
Will this advancing technology eventually replace the need for the human code? Will a machine eventually possess that hard-won, case-by-case surgical intuition we've discussed today? Or conversely, will technology simply raise the stakes, making the human capacity for nuanced, ethical judgment in the face of unexpected, bloody chaos more critical than it has ever been?
Wow. Are we just building smarter tools to help the human chess master, or are we actively trying to build a machine that plays the game entirely for us? And more importantly, what happens when the machine encounters a board that's caught on fire, like a hostile abdomen? Can an AI know when to pivot to damage control? That is something fascinating for you to chew on as you go about your day. Thank you so much for joining us on this deep dive into the Colorectal Surgery Code. Next time you picture an operating room, I know you won't just see mechanics fixing parts in bright lights. You'll see the code wheel, the decision pyramid, and the incredibly high-stakes dynamic chess match happening in real time. Until next time, keep questioning the whys.